All right. We're pleased to have Dr. Betty Maloney, MD, speak to us tonight. She'll talk about the advancements in science and medical education in vector-borne diseases. This talk will introduce viewers to several developments in vector-borne disease that may have escaped their notice, including VectorWise CME is a new online platform hosting free accredited continuing medical education modules on vector-borne diseases such as Lyme disease, babesiosis, Bartonella, Rocky Mountain spotted fever, and others. And more information is available at learnvectorwisecme.org. And Kirk, can you put that up in the chat? The learn.vectorwisecme.org. And a recent paper on alpha-gal syndrome arising from black-legged ticks and the implications from people in Minnesota and Wisconsin. Also, the new clinical trial network coordinating center, CTNCC, for Lyme and other tick-borne diseases, which is conducting pilot studies on Lyme-related exposure outcomes and Lyme disease therapeutics. And on a personal note, Dr. Maloney was essential to the creation of the Minnesota Lyme Association 19 years ago. We are forever grateful for her guidance and support. And thank you much, Dr.
Oh, well,
Maloney.
that's very kind, Anne, and I'll go ahead and share my screen.
Okay.
And of course, without Anne, who is really the person behind all this. Now, let's see. All right. Okay, and I'm going to just make everyone disappear on the side there. All right, so again, I am so appreciative of the opportunity to speak with you tonight. And this is a little different presentation than I normally give because I'm going to hit on a variety of topics and just kind of give you an intro into what I think might be interesting or important in the field because it continues to change. And change in a good way. So we're going to talk about not only VectorWise CME, but I also want to talk a little bit about alpha-gal syndrome. There's some new serologic tests for Lyme disease that I think are a good addition. There was a biobank paper on management of erythema migrans rashes that I would like to talk to you about. The National Academies put out a report on what's called Lyme-IACI, which is infection-associated chronic illnesses. And so we'll talk about that, and then the Clinical Trials Network. So VectorWise CME, that is a new platform for physician education. So I started online teaching free CME back in 2015, and it's really hard to get traction. So then I joined another group called Invisible. And Invisible, we were offering a lot of different CME courses. We went through some rebranding and reorganization. We wanted to have a name that really reflected what we did. So Invisible was kind of amorphous. So we decided that VectorWise, because our focus is vector-borne disease. We want to get physicians and all the clinicians up to speed on what vector-borne diseases are, how they might present in the office, how to test for them, and importantly, how to treat them. And we do this on a free platform because there's so much CME out there nowadays that quite honestly, many physicians don't want to pay the money if they can find something for free. And so what we did when we reorganized, we developed a panel of scientific experts. And so we have those people to draw information from, but also that they can give us a lecture on their area of interest. And so I'm very happy with that. So it is a nonprofit. Everything is free, and we're approaching a lot of the vector-borne diseases from a One Health perspective. And what do I mean by One Health? Well, I borrowed this from the CDC because it's kind of a nice summation. Our people, pets, wildlife, plants, we all share this single planet. And how we treat the environment and how we interact with each other really impacts illnesses for all of us. And so if the climate is changing and ticks are on the move because of that, we'll see differences in tick-borne diseases. We know that mosquitoes are on the move, so we're going to be seeing mosquito-borne illnesses pop up where we haven't seen them. And so we know that if we can protect one sector, so if we can protect our environment, that can help protect us. If we understand the illnesses that our animals are succumbing to, we might be able to understand when we have similar illnesses in humans. A great example are the Bartonella species, because they have so many different Bartonella species. Many of them seem to be animal specific, but we know that they cross over and infect humans as well. So if we learn how to treat Bartonella in a cat or a dog, we might be able to extend that knowledge over to humans. So we have a whole variety of offerings. We have over 40 of them. We're adding new ones every day. Pretty soon we'll be adding a module on alpha-gal syndrome by Dr. Scott Cummins, and he's kind of the leading expert on alpha-gal. I'm tempted to do this, so I did. If we're over on VectorWise, you can scroll through and you can see all the different offerings. Many of them, lots on Bartonella, just because once you get going on Bartonella, you just want to cover it all. And that's Dr. Ed Breitschwart. But we have many things that aren't Bartonella and aren't Lyme disease. So we get Borrelia miyamotoi, a whole variety. And the goal is that if a clinician lands on our site, they'll find something of interest to them. And so that's kind of where plan was on that. Now, here we go. So when we set out doing VectorWise, to give CME, you have to be accredited. And we initially used the American Academy of Family Physicians, which meant that they had to review our courses and then decide whether to credit them and how much credit to give. So we took it upon ourselves to go through a process through the Accreditation Council for Continuing Medical Education. And so we now have the ability to accredit the courses ourselves. So we don't have to go through an outside organization to say that this material is worth 1 CME credit. And in doing that, it gives us more credibility when people come to the website. Mm-hmm. Now, how do we decide what we're going to choose to offer? Well, we usually take suggestions. We take suggestions from physicians, but we also take suggestions from the public. You folks know what physicians are missing. You might know, I have found that people are so well read that you might stumble on an emerging idea before I do. And so if you ever want to suggest a topic, you can just contact us via the website and we'll be open to hearing your idea and see if we can make it work. So don't hesitate to offer a suggestion. Turning now to alpha-gal syndrome. So I don't know how many of you are familiar with alpha-gal, so I'm just going to go through it a little bit. So this is actually a food allergy. And the allergen is called galactose alpha 1,3 galactose. And it's easier to just call it alpha-gal. Now, this is a chemical that is in the mammalian tissues of all mammals except for primates, which includes us. And so what happens is that a tick will bite a person, and within the tick saliva, there is some alpha-gal protein. And that leads to what's called sensitization. So we are not born allergic to things. We first have to be exposed to them, and the body has to say, oops, this is something that we don't want in us. And so that becomes the allergen or the antigen. So what I have in this little diagram is a basal cell. And within the basal cell are histamine molecules, right? And on the edge is the IgG. So if you get exposed to alpha-gal via a tick bite, your body recognizes that as something that we don't want, and it makes IgE antibodies that sit on basophils and mast cells. And all is fine until we introduce that allergen again. So you sit down and you have that steak or the pork chop, or sometimes for some people, cheese or a glass of milk. All hell breaks loose then, because if that antigen binds to the IgE receptor, it causes the histamine to be released. And it's the release of histamine that leads to all the symptoms. And so symptoms are the symptoms of allergy. So it can be hives, itchy, the skin involvement. But then because it's a food allergen, you can get lots with the lips, the face, the tongue. You can have swelling, especially in alpha-gal. It's very interesting, a prominent swelling of hands and feet. And you can sometimes have that as your only symptom. Some people will develop shortness of breath, and a lot of people develop diarrhea and vomiting. And it can be quite provoked. Now, the one reaction we really worry about with alpha-gal is anaphylaxis. So that's kind of the extreme allergic response. And you might get that in addition to the earlier symptoms, or this might be the symptom complex that you have with alpha-gal. What happens is with that massive release of histamine, you can get a drop in your blood pressure, and that makes your pulse race, and you can feel dizzy if your blood pressure gets too low or even faint. Many people will develop tightness in their throat, and they'll find it very difficult to breathe. So anaphylaxis really is life-threatening. Some people I know who have alpha-gal have to carry an EpiPen with them because they run the risk of anaphylaxis. Now, there's some unique things about alpha-gal syndrome as a food allergy compared to normal food allergies. For example, if you eat something that you're allergic to, especially nuts, I mean, it's almost instantaneous, your reaction, but usually within an hour or two. But in alpha-gal syndrome, it can be quite a gap between eating the meat or the meat byproduct and then having your symptoms. So you have a nice meal at dinner and you're up with diarrhea at midnight. And that is unique. Now, the other thing is that the intensity of the symptoms is variable. So you might know you have alpha-gal and you really try to avoid something, but someone slipped bacon into the salad without telling you. Sometimes you might react, 4-6 hours later. Other times you might not react at all. It seems that fatty meats are more likely to cause a reaction than lean cuts of meat. And the thought is that alpha-gal is more attached to the lipids or the fats than on the more protein parts of the meat. And so it takes longer for our body to digest the fats. But once they get released in mass, you get the bigger reaction. Now, this is a map of where alpha-gal has been reported. This was over about a decade worth of reporting. Alpha-gal is not a mandated reportable disease, but they certainly do like to keep track of it. And when you look at that, you can see the darker the blue, the more cases of alpha-gal. And that kind of fits with the Lone Star tick range, right? We know the Lone Star has actually come up to Minnesota, but this is generally the map that the CDC puts out for us. And so that fairly follows that map of alpha-gal, but it really doesn't explain what's going on in northern Minnesota or out to the west. And so there's where a new breakthrough came through. We had 2 papers this year telling us that they have had alpha-gal related to Ixodes scapularis, which is the tick that we have here in Minnesota, Wisconsin, and Ixodes pacificus. So that's the western black-legged tick. And so they had a case of alpha-gal in Washington. And so the importance of this for Minnesotan residents is that I think in the past, people have symptoms really consistent with alpha-gal, but it's hard to get clinicians to buy into it because they can look and say, well, we don't have the Lone Star tick here. And so we're going to change that thought process for clinicians to know that any of the ticks common to the US, at least the Ixodes ticks and the Lone Star tick, could indeed cause someone to develop alpha-gal. And so the symptoms are really the clue to alpha-gal. We test you with a blood test. It's looking for IgG, the alpha-gal IgG, and the cutoff value is 0.1. Now, in the past, some labs have used a higher cutoff when that would yield more false negative results. And so we do want people to know now that the cutoff should be 0.1. Many allergy tests, and especially food allergy tests, can be done with skin testing, but skin testing for alpha-gal is very unreliable. So what do you do if you have alpha-gal? Well, it's avoidance. And this is not easy because mammalian meat derivatives are in all sorts of things. And sometimes you'll see something that says natural flavorings. Well, that could very well be a mammalian meat product. But we also have mammalian byproducts in medical devices and in medications. And so, for instance, there are some people will get heart valves that are from pigs. And so that would not be okay if you've got alpha-gal syndrome. And there are some different medications that also have meat byproducts in them. And I think one of the biggest problems are anything with gelatin. So gel caps can cause alpha-gal reactions. Hospital jello, I mean, there's just a whole variety. And so people with alpha-gal syndrome really have to be their own detective. They tend to want to eat at home because they know that they can trust the food that they're making. And so we're going to have to find ways that we can identify alpha-gal. You know, if you look on food labeling, you'll see food labeling contains wheat, contains dairy, contains nuts. I think at some point we're going to have to also let people know if it contains something that might set off an alpha-gal reaction. So last summer, and now just recently, 2 tests were approved for, or I should say cleared by the FDA for the diagnosis of Lyme disease. Now, let me tell you a little bit about lab testing. So you can buy kits, and that's what most clinics and hospital labs do. So they're buying test kits from a manufacturer. Those test kits have to either be FDA approved or FDA cleared. If a lab has developed a test that is useful, but hasn't gone through the entire FDA process, then that is a lab developed test. And what happens there is the specimen has to be sent to the lab and performed in the lab that developed the test. So it's a little more cumbersome. As you might recall, you had to get your blood to lab X on Monday, Tuesday, or Wednesday because they couldn't process it if it showed up on Friday. But so being able to sell kits to labs will extend the reach of these two new tests. Now, both of them are classified as a modified two-tier test. I don't know if you recall, but it used to be that first people had to have a positive ELISA or EIA test, and then they would have immunoblotting like Western blotting. But then about 5-6 years ago, the CDC said, no, you know what? We're going to allow a system where you do 2 different EIA tests. And if the first one is positive and the second one is positive, that would be called a positive modified two-tier test. So this two new tests now, they are considered modified two-tier tests, but they aren't both an EIA. They start with a screening antigen, so that would be like your first tier, your EIA. But then on that same test strip, there is an immunoblot. If you're doing the IDART IgM, then you're going to have an IgM immunoblot on there. If you're doing the IgG, it'll have the IgG. And so what's unique about this test, and I think conceptually should have improved sensitivity, so fewer false negatives, is that they are looking at different Borrelia species. So they have incorporated into their test antigens from the typical B31 that has been historically used, and then 297. But they've also added in some of the European species, so that if you have been exposed to a European Borrelia species that causes Lyme disease, that'll still be picked up. The interpretation criteria are not the standard CDC. So on the IgM, for example, they have 5 bands that they're interested in. Notice that they've been able to add in bands 31 and 34, which when seen together in particular are very important markers of active Lyme disease. So when you do your test, you always have to be positive or at least indeterminate on the Lyme screening antigen. And then they look at the immunoblot, the band portion of the test. And if you have 2 or more bands from any of those groups, then you are a positive. If you don't have a band from 2 of the following groups, then you're a negative. And so the goal here is that we're trying to have improved sensitivity. The IDART IgG test also looks at antigens from many different species of Borrelia burgdorferi. It includes the screening antigen and then these 12 antigens. And they are like the 10 that the CDC has used, plus 31 and 34. Why they put them on in this order puzzles me, but that is the order when someone is reading a test strip, that they will always be in this order. And to be positive, they really are only concerned with these 6 bands. So to be a positive test, your screening antigen has to be positive, and then you have to have at least 1 band in 2 of these groups. And I say at least 1 band because you might react positively to several at band 39, for instance, from different species. So you just need to have 1 band in 2 different groups. Now, I haven't seen anything that does a head-to-head comparing the iDart to the other tests that are on the market. It would be very interesting. I think we'll get, as they're used more and used more broadly, that we'll get a better sense of how they compare. But I'd love to see a head-to-head comparison. Now, I think there are a couple things that jump out to me on this test is I think it will improve sensitivity. It seems logical that it would, but we'll need to see that bear out. But the other thing that is equally important to me is it validates the testing procedures that IGeneX had been using. So working with clinicians who were not very attuned to Lyme disease, but they had heard through the grapevine about some California lab that everyone tests positive. And they would kind of denigrate the lab without really having any background or knowing what the lab was about or the qualifications and qualities of the lab. So now that IGeneX basically took their lab developed tests, all those times that blood was sent to IGeneX, now that's the same test, but now it's in a test kit. And so to me, it's going to make the test more widely available, but it also says this is a quality lab. You can trust their work. And I think that's really an important message that I plan to bring to clinicians who really don't know much about Lyme disease. The next thing I wanted to talk about was a paper that I had gotten involved in. It was headed up by Liz Horn. Liz Horn runs the Lyme Disease Biobank, which has become a wonderful resource for researchers across the country, because we need better testing. And so people use her samples to look to see if they can develop better tests. And this was a study done over 10 years. And they had sites in Wisconsin and then out in New York, East Hampton. And they did a couple of things. They just got blood from EM patients right when they presented. And then they collected a second specimen 3 months later. And so there was a couple of things that they were interested in. And one was just how does their blood test results change over time? And then they also asked people about symptoms. And so here are some of the results. At the time that people presented for testing, when they first got their rash, only a third of them were positive by CDC criteria. That meant 2/3 were negative. Of those 34% who were positive, they were usually IgM positive. Only 4% converted to IgG positive at the 3-month mark. And that is not what clinicians are expecting. They expect a much, much higher conversion rate. And so this is important information for physicians to know, because sometimes if someone comes in having been treated for early Lyme disease, and they are still symptomatic, but they're not IgG positive, they just have IgM. Many times clinicians will tell them, well, you couldn't have Lyme disease because by now you would be IgG positive. So that fallacy we can address. At the second draw, about 22% reported ongoing symptoms, and these were the symptoms that we wouldn't be surprised by. So it's joint pain, fatigue, and muscle pain. They asked the patients who came back at that visit, okay, so if you're symptomatic, did you go back to see your doctor? And only about a third of them did. We don't know why. There wasn't any question as to why did you decide to go back or why did you decide to not go back. But that's important information because a lot of clinicians assume that a patient who doesn't come back is well. And now we know that that's not necessarily true, at least not for this group of patients. And we were dealing with about 240 patients in this study. Oh, well, that's fun, isn't it? There we go. So we had some conclusions from the paper. First, standard two-tier is insensitive, and I think we've all seen that and kind of beaten that to death. But seroconversion is rare, and that is going to be a new idea for a lot of clinicians. The other idea is people really do need post-treatment follow-up. Their primary care doctors, the people who treat that initial EM, they need to verify with that patient, either by phone or by telemedicine or somehow, that that person is well. And if they are not well, that's when you have to have a discussion about the possibility of retreatment. People always point to the retreatment trials and try to tell us that they don't work. And the trials actually did show some improvement in a subset of patients with fatigue. But all the people in those NIH-funded retreatment trials, they had been sick for a long time. Whereas catching someone early when they're still relatively new in the infection, we think that that's likely to have a better outcome. And the reason we think that is when you go to the early trials way back in the 90s, when they were doing studies on patients with EM rashes, researchers would often report that they had treatment failures and that they retreated them, and then reported that their patients got well. So that little kernel of truth has been out there for about 30 years, but no one's really been able to pick up on it. So here was our chance to get that in front of clinicians for them to think about making sure that the patients got well, and for those who didn't get well, to consider another round of therapy. The conclusion that we really want to do is we want to make an early diagnosis and do the follow-up, because we can improve outcomes and reduce the burden of Lyme disease, which, as you folks all know, it's substantial. And when we think of it across the US population, it's quite a big public health threat. So the National Academies of Science, Engineering, and Medicine, which a lot of people who deal with them a lot will call that NASEMS, but I just tend to call it the National Academies. They came out with a report this spring, and it was how to deal with Lyme infection-associated chronic illnesses. So it's part of that group of infection-associated long illnesses, which really took off and got recognized when people started talking about long COVID. So this is the equivalent. This is long Lyme. And what's nice about kind of using that same terminology is there are certain aspects of these infection-associated illnesses that might be similar across the board. And so you don't have to keep duplicating studies on some of these aspects, so that we can be more efficient with how we do the research and how we spend the money. And so I think the other good thing for Lyme patients is, although Lyme funding has been increasing, the bucket of money for COVID dwarfs anything that we've seen in Lyme disease. So if we can somehow get swept along with the COVID folks, that's fine by me, because research is research, and we really need it. So the focus of this report was to try to look at the evidence for what's causing Lyme-IACI and how do we develop interventions. And so what's kind of interesting, because when I was on the Tick-Borne Disease Working Group, we had a recommendation that we also wanted the National Academies to look at things, but we really, our recommendation is here on the page. We wanted to know what is definitely known, partially understood, and what remains unknown. And for me, that was important because there's a lot of misinformation, even within medical textbooks, about what's known or not known about Lyme disease. And we were hoping if the National Academies looked into it, that would give us some definitive answers. So here's the difference between what we asked for at the working group and what happened. So at the working group, we wanted to look at all of Lyme. We wanted to, let's look at that literature, make sure that we know what we think about erythema migrans rashes, the Lyme carditis, that it's really true. But the National Academy report really only dealt with a long Lyme. We wanted to make sure that we had public stakeholders and patient representatives, right? We also wanted to make sure that any of the experts, whether they're scientific experts or clinical experts, that they represented the whole spectrum of perspectives on Lyme disease. And then unfortunately, the National Academy group lacked a balance. So they didn't have any clinicians that treat Lyme patients with an intent to cure them. And that's, I think, an important distinction. So they had clinicians, but they were generally clinicians whose viewpoint or perspective was, we can't cure you, but we can mitigate your symptoms. And so not having the clinician perspective of, let's see if we can find a cure, really changes how you think about what to do going forward. But there were a lot of important findings in that report, despite it being an unbalanced panel. The one thing I really liked is we need better tests. And they made the point that you're going to run into seronegative Lyme-IACI patients. So when you look at studies that have done, even the newer studies from John Ocott's group on post-treatment Lyme disease, what they do is they require people to have positive serology. And so that keeps a lot of people who truly have long Lyme out of studies. And so now we have, NASM, the National Academy, saying, you need to rethink that because you're going to miss a lot of patients. There are patients who are seronegative. The other nice thing is it again reinforced the idea that these people are sick and it's not psychiatric illness. It's not a psychosomatic illness. We might not understand why they're sick or what's keeping them sick, but it's a medical illness that we need to dig into. And I think that's important because even now I run into people who have been thought to be malingering, or gee, it's all in your head, or they even like to use that, well, it's unexplained symptoms. Symptoms may be unexplained, but now they're saying the symptoms are real. We don't know what the disease mechanism is. Although this report leaned heavily towards immune dysfunction, it did not rule out that persistent infections are a possibility. And so I think that's important because if you look at the working group, we also thought that persistent infection was a possibility along with immune dysfunction. But if you look at the most recent IDSA guidelines, they just will not consider persistent infection as a possibility. So it's nice to have the National Academies saying, oh, yes, it is. There were 6 recommendations that they made. The first was they wanted to prioritize research that improves function and quality of life. And I don't disagree for the need for that research because we need people to feel better. But I still think the priority should be to understand the mechanisms as a way to then move to finding a treatment that would be curative rather than palliative. They did say that they need to, and number 2, create a definition and subgroup definitions, right? Because the patients with long Lyme who have a lot of joint pains and muscle pains might be very different from the patients who complain of lots of fatigue or brain fog. And sometimes you have to separate groups out so you can find the treatment that works for the people with a particular set of problems. They also want to standardize research tools and metrics, and that's important because if you're measuring outcomes using different tools, you don't really know if you're comparing apples to apples. They really wanted to involve biobanks, which again was nice because biobanks are right now outside the government. And so recognizing that these entities exist. And I think patient registries like My Lyme data, they recognize that there's valuable information in that registry. And so they wanted to find ways that they can bring those practices and that data into the fold. They want to have a coordinating center, and I think that makes sense. We'll talk about a coordinating center for Lyme disease in just a few minutes. And again, that's efficiency of research dollars and also research time. It also, when you have a coordinating center, you get people who might not know to interact with each other to learn that they can interact with each other. And then finally, what that will help us do is things that we learn about long COVID. They can then quickly see if they translate to long Lyme or to MECSF or some of the other conditions that fall under that umbrella. And so the Clinical Trials Network, if you aren't familiar with Brian Fallon, I'd like to introduce him to you. He is just a wonder. He has been involved in Lyme disease for about 30 plus years. He's at Columbia University, is a psychiatrist by training, but has done a lot of important work in Lyme disease and did do one of the retreatment trials. I think his was published in 2008. And so these slides are all courtesy of Dr. Fallon. And so what I wanted to show you are the clinical trial networks. And the goal of the network is to collaborate and to make sure that you can fund some small pilot studies, also to build a patient registry. Pilot studies are very small studies that basically look, might this treatment or might what we're going to do to this patient group help anybody? It's not even to say, does it help most people? It's just, could it possibly work at all? And so pilot studies are usually the first step to reaching a bigger clinical trial. And so pilot studies don't cost as much to fund. So then you can recruit donors to get a pilot study up and running. So here are all the different nodes involved in the trial network. Columbia is the coordinating center, but we have places all over the country. Sadly, you'll see they're not in the Midwest. And so I always kind of chide Brian about, we've got a lot of sick people in the Midwest that might be worth studying too. And so I think over time that we will be able to participate in multi-center trials. But there's some interesting things that are going on. For a while, I got to be a reviewer, so I got to really read some of these studies. So if you're familiar with the work of Sam Donta, he has often said, tetracycline is the way to go if you're treating Lyme disease. And so John Alcott is looking at tetracycline per persistent infection. Another gentleman is using pulse ceftriaxone, so pulsed rocephin. And I think that's kind of an interesting take. And I believe that gentleman is an infectious disease specialist. Then looking at some of the dysregulation of the CNS that comes in Lyme disease, there's looking at whether we can stimulate the vagus nerve via the auricular branch of the vagus nerve. And the vagus nerve is part of our autonomic nervous system, and it has a wide range of organs that it innervates. And so working with the vagus nerve might really be useful for modulating all sorts of problems that people have when they have Lyme disease. We have Dr. Cummings looking at how to stabilize mast cells. So the mast cells are like basal cells, are one of those cells that have all that histamine. And when the antigen binds to that IgE antibody on the mast cell. That's what destabilizes it. So if we can stabilize that mast cell, then we might be able to help people who have alpha-gal syndrome. Other people are looking at the effects of microclots and platelet dysfunction, trying to get those things to be calmed down. And then I've got a slide on this pregnancy outcomes for women who've been infected with Lyme disease. So this can be whether you were infected anytime during pregnancy. And what they want to do is follow those children through pregnancy and then out for 18 months. And apparently they are able to do some really interesting things like fetal MRI, and they know how the fetal brain should be developing as a week by week kind of basis. So they can compare fetal development to known healthy controls and then versus the moms and the babies who've been exposed in utero. So I think that's really an important one. Now, they've had like 9 women recruited so far. It's hard to recruit, but if you have an interest, you can, grab that QR, or you can just look up. It's the you can Google the Lyme and pregnancy study, and I think that will be an interesting one because it might be very reassuring, or it might tell us we really need to think long and hard about how we prevent Lyme disease in women who are pregnant and how we deal with it if they should happen to get Lyme when they are pregnant. So the trial network is looking to grab more sites, so they want to build out. So that's what we can push for them finding something to do with us in the Midwest. And then they're really wanting to push out more pilot studies. And I think that's important, whether it's finding an animal model and then trying to translate that to humans would be one approach. They also are looking to way to make it easier to get more patients into studies. So finding definitions or inclusion criteria that aren't so rigid that we aren't capturing the bulk of the patients who have Lyme disease, especially in the people who remain ill after being treated. And so one example of a pilot study that they did actually was started with Dr. Ken Ligner's work with disulfiram. And Dr. Ligner tells a story how a patient heard a lecture and then asked if maybe Dr. Ligner would try that drug on disulfiram on the patient because nothing else had worked. And he did, and the patient got better. So then Dr. Ligner kind of worked clinically to perfect that approach. And so he published 2 papers on that. And then Dr. Fallon's was able to do a pilot study out of Columbia University on disulfiram. And unfortunately, they started their pilot study right before COVID hit. So it's hard to recruit people to come to your center in the midst of a pandemic. But what the conclusion from the pilot study is, there's something here. For these very sick people, this could be a viable option. And so they're recommending that move on to a large multi-site trial. And so that's a good example of how we can use a clinical trial network to test different pilot studies and then help move them through the chain to the bigger clinical trials. So you've been very patient, and I do want to summarize that what I'm trying to show you is that there's a lot of research going on in vector-borne disease. I know in the past I can recall patients thinking that science has abandoned Lyme patients. And I would say, no, that's not the case. We got a lot of great scientists working very hard to try to figure this out. And despite that hard work, there's more to do because we don't understand the mechanisms that are causing people to remain ill. We do know that we need better tests, so the IDAR tests are a step in the right direction, but it would be really great to find a test that didn't measure an antibody response, but actually measured whether or not Borrelia burgdorferi was in your body. And so that is still kind of the test that everyone is going for. It's the holy grail of Lyme disease testing, is to find a direct test. But what I really want to have you come away from this is that science is really important. And right now it is under threat. And we need Congress to fund the National Science Foundation, because that's where the seed money for good science comes from. And so I really want to encourage you. Standing up and advocating for science shouldn't be a partisan issue. So whether you have a Democrat or Republican or an independent congressman or senator, this is the week to contact them, because the Senate is looking at stuff this week. So if you want the science to move forward in vector-borne disease, I want you to pick up your phone and make that call. And with that, I'm going to end and be happy to take questions. And so I'm looking at the chat. Okay, so Karen, isn't the EIA falsely negative? Now, that's an interesting question, Karen. I don't have the exact stat on culture positive, EIA negative, but there definitely is that problem. And part of the problem depends on when you are getting your specimens in the course of a person's illness. So early on, you do, it's not unusual to have a culture positive patient, especially in research centers, who are EIA negatives. Later on, though, I'm not really sure. And then your question, might one positive band be significant in the setting of a tick bite and migratory joint pain? I certainly think it could be. I really believe a lot in the clinical information that we gather. And I think to put such a strong emphasis as many have on laboratory data over clinical data is wrong. And I know Rich Horowitz has published on the migratory nature of joint pain and how that's a real marker. So I think you're right on the money, Karen, that that even a single band can be significant when it's coupled with a good clinical history. Let's see, treatment failures. Isn't treatment failure? Oh, yes, thanks again, Karen. So are treatment failures a clue to look for co-infections? Absolutely. So when there's a treatment failure, one of the first things you have to ask is, well, did I have the diagnosis right? I mean, was it really Lyme disease? Okay, yeah, it was really Lyme disease in this instance. Well, what else might it be? Could it be the Lyme plus? So you can have someone whose Lyme was perfectly treated, but they've got babesia and you haven't touched it, or they've got Bartonella and they need treatment for that. And so that's an excellent point, that when people have been treated for Lyme disease and remain ill, you have to look at other things that could mimic that. So a different vector-borne or a different infection of any sort, it doesn't even need to be vector-borne, can certainly prolong the symptoms and be confusing. So I think that's great to know. Let's see. Yes, and early antibiotic treatment often leads to a seronegative state. And what that means is, if I give you an antibiotic when you're just developing your antibody response, you develop that antibody response because pieces of Borrelia are in you and your body's recognizing them as foreign. But if I kill that Borrelia off, or most of the Borrelia off, before you've made your full antibody response, you stop making antibodies. And so you can have people, and this has been in the literature since 1988, who actually are still infected, but they don't have a positive antibody test. So they're seronegative. And so that goes back a long way, and it always interests me. So many of the things that we know to be true, that we know that the evidence for, it's like people forgot that this work had been done back in 88. It's not a big new discovery, but it just hasn't been taught for reasons that are unclear to me. What is the contact for the biobank? Thank you for that. I would say, I think you're going to have to Google it because I don't have it offhand. So if you just Google Lyme disease biobank,
Okay.
because they have a website, and they are always looking for specimens. Sure, you can have these slides. I'm always happy to share my information, and if you have the video, perhaps that will be something that you could share amongst other groups too, Anne and Judy. So the more the merrier, I think. Let's see. Any information you can give us about free CME? You've got the website. So it's, all you have to do is go to VectorWise CME.org. You don't even need the learn part. I think that's probably the best. And because when you're talking to clinicians, you can point out that it's ACCME accredited. And I think to clinicians, a lot of clinicians that'll strike a chord. Oh, okay, that's worthwhile and a worthwhile site for me to visit. Oh, I'm sorry, Amy. I am probably not the person to answer your question about something to alleviate fatigue, which is such a horrid symptom. I guess if you know, there are clinicians who are dealing with this more natural, non-pharmaceutical. I don't know if you've had the opportunity to see a clinician, either a naturopathic clinician or MD or DO or nurse practitioner, PA, who has been trained in using non-pharmaceutical approaches to Lyme disease. I'm sorry that I can't be of more help to you tonight on that. Thank you.
Can I add a quick thing, Amy?
Yeah.
I just saw this afternoon, Dr. Horowitz is doing a free talk tomorrow. It either starts at 5 p.m. or 6 p.m. on fatigue and how to look into the root causes and mitochondrial disturbances and how to approach different ways of healing fatigue. It's a free Zoom that you can sign up for. I can try find info online before the end of our meeting, but otherwise, if you just Google, I don't know where I saw it, somewhere on Facebook today, Dr. Horowitz.
Oh, and look, Karen Ricotta has added about Dr. Bruner's books online. So that would be another resource for you, Amy.
Thank you. My situation does involve mitochondrial dystrophy, and I started with the Lyme with the pain, but that has helped with natural courses, but the debilitating fatigue is really, I'd like to get a handle on that. If you can put the link in the chat, that'd be really good.
Britt, do you have that link?
I haven't found it yet, but I'll keep looking.
I've got the link.
Okay.
I posted it in our local Kansas City group. I'll
Oh,
try to
maybe
get it.
that's where I saw it.
Yeah, if you can post it here, that would be great, Julie.
Okay, I'm doing that. I get it right.
You know, interestingly, and not to push this at you, Amy, but of the 2 retreatment trials that found a beneficial effect of ceftriaxone or Recephin, it was on the people with severe debilitating fatigue. And the treatment effect, or it was really a significant improvement in their fatigue. So I don't mean to push that on you, because maybe there are other treatments that can give you that same bang for your buck. But that was one of the things that actually the retreatment trial showed, is that people with fatigue can respond to retreatment. But again, lots of, different things that can be tried. I don't see any other questions in the chat. Is there any conversations? Is there anything you needed me to expand on or explain differently?
Sorry, I have a question. Are you familiar with the research at Northwestern University with a different antibiotic?
I think you're talking about Kim Lewis's work.
Yeah, I think it's called piperacillin.
Oh, piperacillin.
Yeah, it's related to penicillin.
Yeah, it is related to penicillin. And I did not read that paper, but I've read reviews of the paper.
Primarily getting epidermal with pork.
Oh.
And I
having.
Oops, we're getting some feedback. If you could put yourself on mute if you're not actively asking a question, that'd be great.
And so my understanding was to the levels of piperacillin that you would need are not readily, you'd really have to dose up what we traditionally use for that drug. But I do not know the details.
Well, I think the person that worked on it was Brandon Jartrus.
Jutras, yes.
Oh, Jutras. Okay. Yeah. And from what I read about it, it says that a very low dose of the antibiotic is required.
Well, that's not what I took away from the iLabs chat, but I can, we can look at that, Carla, and maybe I can send a response on to Britt that she could post on the website or send it out to you.
Yeah, I think this is probably the latest research in the use of this antibiotic. I mean, it's an old antibiotic, and they're using actually less than what you would utilize, like doxy, much less than doxy.
Well, remember, when we're talking about drugs, we don't, 200 milligrams of doxy, it isn't comparable to 200 milligrams of piperacillin, or so it. Right. So that I want to be careful that we make sure but I don't think I would be able to read the paper now while we're chatting. But I can look at that and see. It looks like it was in a mouse model. And yes, the doses were more than doxy. I'm just reading a summary. I'll have to look at that. But okay. Of course, the reason we do pilot studies is we don't want to jump from a mouse model to humans. If we can do a bridge and do a pilot study first. So I think having animal models is a great starting point, right? But oftentimes things don't pan out when we carry it over to a human study. So I don't want to say it's not going to work. But I wouldn't expect that clinicians are going to start prescribing piperacillin for folks. Now, that isn't to say that some won't, and I won't say that it would be bad to do that, but you would have to really be in informed consent. Oh, and Karen's got an interesting thing. Most of the clinicians in ILADs are indeed using combinations of antibiotics and not just a single. For instance, piperacillin is a cell wall drug, and so as a penicillin, it could change the morphology of Borrelia if you use it on your own. Just you would change from the typical spiral form of Borrelia to the cell wall deficient form. And so that then has to be attacked with a different drug. So this is why many clinicians use combinations of therapy to get at the different morphologies that are coming on. Oh, good, we've got Dr. Horowitz's website. That was all good.
I'm sorry, that link, I had a typo in it, I'm sorry. I'm sorry, I'm trying to get to it.
I
On the,
appreciate your help. Thank you so much.
on the, where it says SCI WG HC0XS IS2A. I don't understand why that didn't go through.
Amy, I just forwarded you the email invite.
Yeah.
Okay, good.
So, you know, I wasn't planning to really talk about treatment. And Karen again makes another interesting point, which is, although we tend to use combination drugs, bicillin LA has been very effective for a lot of patients. And that's that it's a form of penicillin, and you often get several injections a week. But sometimes that, depending on the patient, it might be 2 injections a week, and it can often be for a longer period of time, but that way you don't have to have an IV because IVs come with, you know, risks. And so that is interesting to me now that she mentions it. But, you know, the people that I know, Karen, they often did have something besides just bicillin alone.
I would say not in my patient population.
Oh, you just had them on bicillin?
Yeah, I mean, at a certain point, the gut cannot take another antibiotic. And when they can't take antibiotics, then the LA bicillin is well tolerated, and maybe, you know, over 18 months, the gut heals, and a lot of times they get, you know, 80% better. But, you know, it just gives a low level of penicillin. You don't get high levels of penicillin with LA bicillin.
Exactly. And, you know, depending on what antibiotic you use, some of them, it's just the constant pressure of the antibiotic, and you don't need those big peaks. Whereas others, you need that big, you have to get way above the MIC. So that's a very interesting drug, you know. And you can get bicillin, by the way, out of Canada much cheaper than you can get it here in the state, US. But I guess I have to be honest, I wasn't really thinking about treatment when I came in tonight. So my apologies. Thank you, Karen, for being here.
I have a question about why is Lyme and mast cell and mold all related? I've done antibiotics off and on for 20 years, not getting much better. And now my husband said, okay, you need to be tested for mycotoxins, which my levels are very high.
Okay, and I'm sorry about that. I don't know that they're necessarily, I don't think that having Lyme disease predisposes you to mold, but I think that certainly if you have mold and you have not adequately addressed that, and then it might make it more difficult to treat your Lyme disease. It's almost like, or if you treat your Lyme disease, you still might be unwell because you have mold that you have to contend with. Kind of like we can treat your Lyme disease well, and if we don't touch your other vector-borne diseases or other infections, that you still won't feel well. So I don't know that there's a link. And again, I'm going to defer to Karen if she wants to pop in here. I don't know that having Lyme disease makes you more susceptible to mold. Karen, what's your understanding?
I think certain people's livers can't clear toxins very well. And, maybe they've had a certain amount of pesticides or stress or trauma, not enough sleep. They just a certain point in which you can't get rid of toxins. And then the mold toxins build up. And then your immune system goes offline and all sorts of infections pop up. That's how I see it.
Okay.
Well,
And
I
that
was
makes
wondering,
sense.
I did genetic testing, and they're like four genes for mold reactivity, strong reactivity to mold, and I have all four. So, I really don't know why practitioners are not utilizing genetic testing more when it talks about, immune function, clearing drugs out of your system. I went back and entered all my information into Chat GPT, and it listed, all the different various areas. If I take something, the half-life for you may be 24 hours. The half-life for me may be, a week.
Mm-hmm.
So I don't understand why practitioners are not looking at genetics.
I cannot speak to that, Carla. Part of it is training. So, what you learn in medical school and residency, you have to add to it as you're out in the world practicing. So some of it is just you get more experience the more you see of patients. And this is a great instructive in that patients can actually educate clinicians. You can bring information to have us say, oh, I didn't think about that, or I haven't been taught about that. And so there is in medicine a constant learning, but why people are not availing themselves of genetic testing, I can't really tell you. Now, that's a great point too about how you fed that into Chat GPT.
Well, it's a Chat GPT that you pay for. There's a free one, and my husband worked for IBM. We do the one that I think you pay $20 a month, and it listed all this out, and it made such sense why I take something. Even supplements bother me. Different supplements can bother me. But I think this is so important. You go to a primary doctor, and let's say you have thick blood, he gives you Plavix. Well, I was on like a half a Plavix. Well, when I compared it to my genetic functioning, I shouldn't even have Plavix. So, I'm really feeling that, and I know genetics just loads the gun. I understand that. But, I think that so many practitioners need to get on the ball and learn about genetics. And I brought this up to my Lyme doctor maybe 7, 8 years ago. And, he didn't even know what MTHFR was. So.
Well, I think you're making a great case for being an advocate, for yourself, learning about your body. And I think that's an important message. So we can encourage people to pick up new skills. But I think you can always also be your own best advocate. And now that you have that information, have you given it to your providers, and do they find a way then to tailor therapies based on the information you have through your genetic testing?
I haven't given it, I mean, I just actually got it all in. I had to enter it all by hand. I tried to scan it in, but ChatGPT, wanted me to enter it by hand for some reason. I entered it by hand and I have it, and I asked ChatGPT to put it into categories, categories such as detoxification, methylation, those different categories. It did that. And, I'm going to be sharing this with my provider. But obviously I was taking a supplement that was just making me sick. So I asked ChatGPT, based on my genetics and my mycotoxin profile, I entered that also. I said, why is this supplement making me sick? And it said, well, you're not clearing this from your body, and you need to get off of it for 5 to 7 days. I mean, this is just AI talking. I know a provider probably, with their experience is probably better suited to make some of these decisions. But because I'm so ill on this supplement, it's like, okay, well, I'm going to try that. Very interesting.
But even without, because this is an important point, patients are the experts on their body. So if you're given something and you see a change that is not beneficial, you should feel very free to say, this is not helping me. And to bring to whoever suggested that you take that supplement or whatever, to say, I might not know the mechanism as to why this is making me sick. In your case, you do, but you at least recognized that it was making you feel unwell. It wasn't helping. And I think for whatever someone prescribes anything to you, if you judge for yourself that it's not helping, then you really have to trust your own instinct on that and have that discussion. Because that's a much more valuable way to approach it than to either stop and not tell the clinician that you stop, because then they won't know. And also they might gain information that they can use on a different patient who has similar circumstances. So always trust. If you're taking something that you think is helping you, even if someone says, oh, it couldn't be, I think most patients have a pretty good sense of what is making them feel better when they take something new, or what's making them feel worse. And so do trust your own internal judgment.
Okay. Thank you.
Well, thank you, Betty, for all the work that you've put into this.
Well,
passion and we know that you are making a difference. And I know we've had you long enough, so I think it's probably time to close it up. And if everybody would like to unmute themselves, we could say thank you to Betty.
Yeah, thank you.
Remember
Betty.
to come again and
Thanks, Betty. It
do
was
some of these great programs that.
Really appreciate this forum. Thank you.
Well, it's been a pleasure, and I love that you're such an engaged audience. That's really a delightful thing. And if anything changes on the policy front, because that's really where I do a lot of my work now, I'll be happy to let Anne and Britt know and circle back.
Thank you.
Thank you so much.
And I will look up piperacillin and see if there's anything else I can add to the conversation. I'll pass that along to Anne. I have your email, so.
Thanks for your work helping so many.
Thank you.
You're welcome. Well, thanks again, everyone, and I hope you have a storm-free late evening.
Yes.
Thank you.
Bye-bye.
Thank
Bye.
you.
Okay.
Betty, are you still on here? Nope. Okay. And if you want to follow up with her, then Kurt could either